Hello, I'm Professor Patrick McGorry. Welcome to today's webinar. Before we proceed, as Executive Director of Origin, I would like to acknowledge the traditional custodians of the land on which we work around Australia and pay my respects to elders both past and present.
Well, hello everyone. I'm here today to talk about attention deficit hyperactivity disorder and to present to you a comprehensive approach that's worked well for me over many years as a psychiatrist looking after children and young people at the Children's Hospital. I'm hoping to go through some of the key definitional issues and in particular emphasise the importance of culture in how different cultural groups can view ADHD symptomatology, look at some of the prominent comorbid conditions, key developmental outcomes for ADHD, the important etiological issues, and in particular outline for you the biological story that's emerged in this field, and then finally offer you a practical and holistic treatment approach. To begin with, ADHD, like all mental health conditions, is defined by a particular pattern of symptoms that's linked to impairment. The school classroom, the playground at home, wider social situations such as the netball program or the local footy program, because it's impairment that actually makes the diagnosis. As you'd be aware, any particular psychiatric symptom can emerge at any particular point in time, but without associated impairment, that does not make a disorder. Impairment, having been defined, needs to be inappropriate for the young person's stage of life. So age, gender and IQ are critical factors when considering impairment that ensure we're comparing apples with apples and oranges with oranges. In other words, girls need to be compared to other girls within any particular society or social group, and likewise with respect to IQ, it's very important to make sure that children and young people don't have a mild intellectual disability, because again, as you approach that figure of a full-scale IQ index score of 70, the chromosomal genetic anomalies tend to increase exponentially, and therefore it's very important in that mild intellectually disabled group that you again compare young people with an ID to others with an ID, because attentional issues, mood regulation problems, impulse control problems, etc. are exponentially increased in that group. However, given that you have compared your young person you're seeing with potential ADHD to others of that age, gender and within that IQ range, you can define impairment, and that can lead to the diagnosis. It's also incredibly important that informants from different perspectives are gained, so that you again gather a picture of the child across their whole world. It's very important to remember that as you grow and develop, so how you present in different situations tends to become more uniform. But children, by definition, are very environmentally sensitive and environmentally determined. So how a child is in a school classroom with a particular parent, or a particular favoured aunt or uncle, how they are behind the shelter shed, or at the end of netball practice or footy practice, can be very, very different, and that's quite normal. So it's very important to get, as a minimum, information from parent, from key teacher, as well as from the child themselves. One of the reasons for this is that agreement between parent, teacher and child reports are known to be very low. In fact, children are very good at telling us about their internal anxiety and mood states. Parents are very good, as are teachers, at telling us about children's external problems and externalising issues such as oppositional defiant problems, rule-breaking problems, impulse control, motor drivenness or inattentive information processing difficulties. So it's important that we gather information from all these sources. With respect to the approach to assessment, it's incredibly important that we understand that we have to assess kids and young people over a course of time. A cross-sectional assessment is really not worth much compared to a longitudinal assessment, because over a period of 6 months, certainly 12 months, you gather a huge amount of information about the child and young person's experience at that developmental stage, and more particularly as they move from one developmental phase to the next. And that can be enormously important and helpful in terms of making the diagnosis. With respect to the key aspects of ADHD, in its current iteration, the DSM nosology asks that there be problems with information processing on the inattentive dimension, troubles paying attention, concentrating, losing things, forgetting things, planning, organising difficulties, and or on the hyperactivity and impulsiveness dimension. The difficulties need to emerge before the age of 12 years and be evident at least across 2 settings, from parent or teacher reports as a minimum. And the impairment can be in social, academic, or in wider social functioning, and not due to a pre-existing psychotic mood or anxiety disorder. Interestingly, with respect to pervasive developmental disorders, it used to be a exclusion criterion, but now it's known that ADHD has a greater than chance association with pervasive developmental disorders, and the two can coexist within the current nosology. There are 3 main types of ADHD. There's the inattentive type, where the inattentive dimension is linked to impairment. There's the hyperactive impulsive type, again linked to the impairment dimension. And then there's the common combined type, where both the inattentive and the hyperactive impulsive dimensions are linked to impairment. It should be noted that the inattentive type and the combined type ADHD are the predominant 2 types seen in clinical practice, because the predominantly hyperactive impulsive type tends to behave the same as the combined type and to be linked with it. However, in epidemiological samples, it is possible to identify a separate hyperactive impulsive type. It is just much rarer in clinical practice than identification of a combined type or separately the inattentive type. Interestingly, you did tend to see a gender difference between the combined type and the inattentive type, with girls predominantly presenting with the attentive type, associated sluggish cognitive tempo, leading to often academic and social difficulties in the school setting, whereas the combined type is predominantly seen in boys as opposed to girls, and is by far the most common presentation. Now, I just want to digress and note some important cultural issues. We exist in a world where Western civilization and the Western health paradigm is preeminent, and it is often not questioned. And yet, when we have a particular child, young person and family with us, we are viewing them and they are viewing us through a whole set of cultural and social lenses. And I think it's important to recognise that these lenses can affect what we see and what we don't see or we choose to ignore in their presentation. To give you an idea of some of these issues, if we consider what is available via the internet in terms of general information, if one considers this information, a young Indigenous child had to attend court and was charged with receiving a stolen Freddo frog, in addition to a note that read, "Do not enter genius at work," which he was given by his friend. This child had no prior convictions, and yet in his particular social context it was deemed appropriate that he face court. If one moves to the northern part of Australia, this young man is Indigenous and was walking down the street and was detained by the police and placed in jail for no apparent reason. Indeed, on presenting to the magistrate's court, when there was no reason given for his detention, the magistrate ordered him freed, but the court security guard, on receiving that instruction to free him, opened the door leading to the court cells, in other words, to incarcerate the young man again. This only ceased when the magistrate intervened to actually personally ensure that the young man was released from jail. He had done nothing wrong except be an Indigenous child walking down the street. Now, if we juxtapose this with, again, a very important and celebrated case in the United Kingdom of an Oxford University student described as upper class, an aspiring heart surgeon, medical student at a very important university, who, in a drug-fueled rage, attacked her ex-partner with a bread knife and almost killed him. When facing court, was not given a custodial sentence initially because the judge said, "You are clearly highly intelligent, though you had an immaturity about you which probably was not commensurate for someone of your age," and sought to not incarcerate this young person in jail. The social and cultural blindness evident in these three, if you like, case studies or situations, I think emphasises for me the importance of being so careful that we don't operate in an unknowing way, particularly as psychiatrists and mental health professionals, without considering the potential blind spots that we might have and what we might miss in the young people before us. Now, I'm not the first to have raised this. If we look here at a very important quote from Vygotsky, famous for his work on mind and society, Developmental Neuropsychology, he made this point: every function in a child's cultural development appears twice, first at the social level and then later at the individual level. In other words, first between people, so-called interpsychologically, and then inside the child intrapsychologically. In other words, all high functions, according to Vygotsky, originate as actual relationships between individuals. To put that in another context, if you were in that West Australian or that Northern Australian context as an Indigenous young person, you can imagine that your inter and then intra-psychological development would be very different to that of the upper class young woman at Oxford University and in the developmental setting that she would have had. And this is something that we, as mental health professionals, need to take into account when we're seeking to define and then manage conditions like ADHD. Another very important point is that ADHD in adults is not the same as ADHD in children. Discontinuity indeed seems to be the main finding, and indeed the nature of ADHD in adults remains quite unclear, and childhood findings cannot be extrapolated to adults. There's a very important editorial in The Lancet that Javier Castellanos wrote, outlining the fact that adult ADHD seemed to be quite a separate field to child ADHD, and many of the emerging biological findings, one of which I'll mention in particular, support this point. But now let's move on to key comorbid conditions. Interestingly, ADHD, almost by definition, occurs at least with one or more comorbid conditions. It rarely occurs on its own. Oppositional defiant disorder through to frank conduct disorder, anxiety and depressive disorders in the young, separation anxiety in the older teenagers, social anxiety, through to depressive disorders, both persistent depressive disorders, what used to be called dysthymia, through to frank major depressive disorder, particularly in the teenage years, tic disorders, as well as three very important comorbid conditions that we can do something about readily: language learning disorders, speech and language disorders, and developmental coordination disorder. Language learning disorders, spelling, reading, maths, writing disorders, can respond readily to educational mediation, tutoring. Speech and language disorders, speech therapy. And clumsiness or developmental coordination disorder readily respond to motor learning programs delivered by a psychologist or an occupational therapist. very important we don't miss these three key comorbidities, because they can be effectively managed, and a bit like the paediatric dictum of not missing the blind or deaf child, I think it's very important that we and young people don't miss these three important comorbidities. If one looks at this Venn diagram that was actually given to me by Eric Taylor from his 1991 monograph, these are epidemiological data, it shows how interleaved ADHD is with key comorbid conditions. And the one point I would make to you is that this is epidemiological data. If one was to do this with clinical data, we would see the circles overlapping far more keenly and clearly with relatively pure ADHD reduced to just a very slender crescent at the very end of the circle, because the overlap would be almost complete. As Michael Rutter and colleagues have emphasised, we have to have a flexible approach given the high level of heterogeneity between these developmental disorders and their overlap. This is particularly important for ADHD, as it is with autistic spectrum disorders. And also, there's a need for research to become far more closely linked with real-life clinical practice, given the fact that in so many instances, research studies have almost partial out key complexities that are what the clinicians have to face up to and manage day in, day out. And as these researchers mention, much more needs to be done that's pragmatic and helpful for those that cold-face. Again, Vygotsky's words I think are very, very important. Childhood is a complex dialectical process. There's unevenness in development, and most importantly, there can be metamorphosis or actual qualitative transformation of one type of condition into another that's actually occurring in a fits and starts way that's part of development. Development is not some form of smooth, linear regression process, which is how it can be interpreted often through statistics graphically. It is complex, uneven, fits and starts, and there can be genuine change in core phenomenology from one type of condition to another. I'd like to now go through with you three of the major developmental trajectories for ADHD from childhood through to adulthood. Perhaps the first and most important are the combined type children, hyperactive, impulsive, inattentive children that have a predominantly inattentive picture in the teenage years and the adult years. This is often the case as the hyperactive impulsive elements diminish throughout teenage years and into adult years. And along with the skills that the young person's learned to overcome and manage their symptoms, often treatments like stimulant medication or non-stimulant medication can be used on an as-needs basis rather than having to be used every day, and then only in high-stress, novel, high-stimulus environments, such as a job interview or preparing for examination. ADHD, combined type in childhood, can also lead to frank depressive disorders, either persistent depressive disorder, what used to be called dysthymic disorder, with or without major depressive disorder, as a primary phenotype in teenage years and then into adult years. Often either the persistent depressive disorder, major depressive disorder, or the two of them together, so-called double depressive disorder, tends to be remitting and tends to fluctuate and be intermittent in its presentation. But most importantly, once treated, often underlying will be the inattentive information processing difficulties separate from the depressive disorder that indicate the underlying thread of ADHD that remains in the depressive phenotype. So I'm forever being referred by psychologists working with me or near me or referring to me young people where they've effectively, through interpersonal therapy or cognitive behavioural therapy, with or without the use of an SSRI such as fluoxetine, managed effectively the depressive disorder episode, only to have ongoing ADHD information processing difficulties remain affecting young person, and then separately that ADHD needs to be managed. Final pathway is very distressing. Now, the ADHD combined type group that go on to develop frank conduct disorder in the teenage years and then antisocial personality disorder in the adult years. This is distressing because the odds ratios in terms of this progression can be as high as 10 or even 20-fold and are often linked to resource-less families and resource-less communities afflicted by poverty. This is distressing because these are often the families that may or may not be offered medication for their ADHD of combined type young person, but precious little in the way of skills training or school supports or wider social supports. There are relatively few mentors for this group, and so the oppositional defiant difficulties grow into the frank conduct disorder, rule-breaking difficulties, the fire setting, lying, thieving, stealing, truanting from school, running away from home, etc. And so the young people, early family breakup, get involved often in a peer group with other young conduct disordered individuals, and from that involvement as fodder in organised criminal activity, and also the problem particularly for females of early pregnancy and childbirth and child rearing. And in that context, often alienated from the resources of society, and because they are incompetent criminals, in the sense that they, the same way they are incompetent students, they are caught by the police, come before the courts, and end up in prisons. Okay, what do we know about ADHD in terms of etiology? Well, first point to say is that there's been quite an emphasis on biological risk factors in this condition, and quite appropriately so, because effect sizes tend to be around a standard deviation for biological risk factors, and then around half a standard deviation for psychosocial risk factors in the field. However, this biological emphasis, unfortunately, because of the availability of medications for this condition and the power of the pharmaceutical industry, tended to emphasise the biological risk factors, and ADHD became not just a developmental disorder but a neurodevelopmental disorder, and indeed medication was seen, because of standardised trials, as a first-line treatment. However, at a closer inspection, it became clear that a vulnerability, risk and resilience model was most appropriate for understanding ADHD, with many factors of small effect, be they biological factors of small effect, psychological, social and indeed cultural factors of small effect, adding up in myriad different ways to lead to the onset, natural history and indeed finally affecting the treatment response of ADHD. This is very important because ADHD is truly, holistically, a developmental disorder with delays at biological, psychological, social and indeed cultural level evident. But the biological risk factors, I think, were overemphasised primarily because of the availability, particularly of stimulant medication, dexamphetamine, methylphenidate, and indeed I think now we are seeing that the biological story has not delivered any particular factors with big effect sizes or big odds ratios influencing the clinical phenotype of ADHD. So we are left with an understanding of ADHD primarily being a final pathway of myriad different small effect biological, psychological, social, cultural factors adding up in different ways in many different combinations to lead to the final phenotype. Just outline a little bit of the biological risk factor story for you. Working memory and response inhibition are perhaps two of the most important neuropsychological and then cognitive neuroscience factors that have been looked at. I call them cognitive neuroscience factors because non-human primate studies and early order mammalian studies have shown the brain behaviour relationships in exquisite detail of the working memory construct as well as response inhibition construct. And so therefore we know a lot about the parts of the mammalian brain that underpin these functions. And there's no doubt that disorder and dysregulation in both working memory and response inhibition have been very important in explaining a degree of the variance of ADHD in any given population, but not the preponderance. For example, we know up to 30% of all ADHD sufferers will not have any biological risk factors, in particular working memory or response inhibition difficulties that are driving their ADHD picture, but rather there will be an admixture of psychological, social and indeed cultural factors driving the onset and progression of their ADHD. The working memory response inhibition factors led to many different imaging studies, initially structural and then functional imaging studies that attempted to unpack how brain structure and function might be altered in ADHD sufferers with these sorts of biological risk factors, working memory, response inhibition difficulties. What we noted was that particularly differences were evident in children, but many of these differences were not evident in teenagers, young people and indeed adults. An example is a very important paper just published by Hugeman and colleagues. I was one of the co-authors in the American Journal of Psychiatry, which showed that grey matter surface area anomalies were evident between ADHD sufferers and typically developing participants. But this was only in childhood. The differences in surface area were not evident in the teenage years or the adult years. Very important point, because so often what we know about ADHD in childhood is unnecessarily extrapolated into teenage years and adult years as if it's the same condition. And yet we know that there are many more additional factors that can play a role in teenage life and in adult life. An example is the emergence of bipolar disorder and the emergence of psychotic disorders as very real factors that can affect a minority of these individuals, in addition to the very important depressive disorders that I mentioned earlier as one of the main outcomes of childhood ADHD. The other critical factor that emerged in the imaging literature was the fact that findings at a group level could not be applied to a particular individual before you. An example was Javier Castellanos' seminal Journal of American Medical Association work published in 2002, which emphasised the important difference between brain size with a decrease in both males and females with ADHD at a group level compared to typically developing males and females, whether the child was aged 6 or 16. It seemed to be a developmental stage independent decrease in brain size. What was fascinating is when you looked at individual cases, you couldn't predict whether a particular typically developing child or a particular ADHD child would have a large or small brain, because at an individual level the data was much more confused. The group level findings, the regression lines that demonstrated the difference were only evident at the group level, but you couldn't use that information to predict whether that particular young person before you had a large or a small brain. In this way, when we think of etiological issues, it's very important to understand that group data does not tell us about the unique admixture of biological, psychological, social, cultural risk factors that the young person before us and their family present. We have to work that out at a clinical level, one-on-one with them. And in the same way, when it comes to treatment, particularly with medications, we have to look at treatment response in the same way. And I'll outline that important issue about treatment response at an individual level a little later. When it came to genetics, let us move on from imaging, we found the same complexity. Key candidate genes failed to deliver odds ratios much above 1 unity in terms of their risk associated with ADHD. We did, however, see that there was a benefit if one looked at particular cognitive neuroscience findings. In other words, often particular candidate genes might have an odds ratio of 2 or even 3 linked to a particular working memory construct, verbally, visuospatially, or response inhibition construct. But this was not evident when it came to the ADHD phenotype. Findings not much above unity, 1.01, 1.2, 1.3 odds size, odds ratios. This showed us again that even though candidate genes were significant, the effects remain small. And to date, the most recent paper has found on genome-wide scans up to 12 key sites that might be linked to ADHD. But again, there's no evidence that these sites contribute to the overall variance of ADHD in populations around the world, anything but a small effect. Epigenetics has arrived and is clearly showing us that the environment shapes the developing mind and developing brain equally. And this is very, very important because of its implications in terms of holistic treatment. It is really not enough just to provide a molecule in terms of a drug, in terms of managing ADHD, without there being attention given to the learning environment the child's in academically and socially, and the skills that the child can learn through their self-understanding and through their internalising of new ways of coping that can actually aid them overcoming their symptoms. When it comes to psychological factors, I'd like to mention some key ones now. These psychological factors, interestingly, all form, if you like, one unitary dimension. In other words, the more of them you have in terms of better parental functioning, better marital functioning, better family functioning, better peer group functioning, the more resilient you are, the more protective factors you have. And likewise, the worse your parental functioning, marital functioning, family functioning, peer group functioning, the greater your risk. This has been understood in many ways, but primarily we, in my unit, use the empathy, attunement, sensitive and responsiveness approach to defining human relationships. The implication being the more empathic, attuned, sensitive and responsive your interpersonal relationships are, the more you can truly, sensitively and in a responsive way change because you can understand the situation in life of the person you're in relationship with, the more resilient you are. But likewise, the more this is a problem, the less empathic and attuned you are, the greater the risk. Likewise, how flexible, adaptive, regulated your affect and how good your problem solving is clearly affects your ability to function at both a parental level, in terms of parent-child relationship, marital, family functioning and peer group level. Apart from risk factors, initially enshrined in the Zubin and Springs vulnerability risk model, protective factors have emerged as being very, very important. And I have to acknowledge here Martin Seligman and the positive psychology movement that's emphasised how crucial these aspects are. Here we've found that despite, in a sense, minimising risk factors, we can aid and develop protective factors. And here we've seen a dramatic opportunity to intervene and to help children and young people with ADHD and associated conditions, because we can try and find what they're good at and increase it and amplify it as a way of building engagement and rapport, and then helping them begin to, having had success with increasing their resilience factors, begin to work on minimising their risk factors. Here, things like their coping styles, their problem-solving skills, their sense of purpose and belief in themselves, and their hopefulness for their situation in life, both now and going into the future, are crucial. Likewise, if we can improve, if not through relationships with mother and father, find caring, mentoring relationships, and these can often aid not just social development but also tutoring for academic development, with a tutor that also offers a degree of empathy and attunement, and can help with some social skills learning as part of the tutoring they offer academically, can have enormous impact and effect in terms of helping young people. I might just frame this for you now in terms of an approach to intervention that's comprehensive and holistic. I believe, whether it's a child or young person, and you've got to remember I've primarily looked after young people from the age of 6 through to 16 across the course of my career over the last 20 plus years, I've tried to look at minimising risk factors and maximising resilience or protective factors. At a biological level, that's meant often using medications to minimise executive function deficits, but also maximise arousal regulation. Psychologically, I've tried to minimise the tendency of young people to externalise blame and to say it's all your fault that I'm experiencing these difficulties in my life, but rather enhance a more balanced self-reflection. And socially, I've tried to minimise a hostile, critical set of relationships with siblings, with mother, father, family members, etc., and really enhance a confiding, nurturing, and a consistent approach to positive reinforcement of desired behaviour and attitudes in the home and wider social environments. And most importantly, I've tried to monitor the outcomes for these risk and resilience factor approaches across developmental phases. So certainly every 6 months and certainly every 12 months I've tried to have a comprehensive re-review for my cases so that I don't miss the child moving from one developmental stage biologically, cognitively, socially, culturally, and therefore having a whole set of new skills potentially and opportunities for treatment to ensure that I've got the balance right between the medications and psychological and social treatments that I've put in place. I always focus on psychological and social treatment at being the heart of management of ADHD, hopefully for a period of around 4 to 6 weeks, because it can take up to 6 months for a new habit formation and genuine internalising of new coping styles, belief systems to become part of the person's psyche and their day-to-day lives. I also believe in crisis management so that you can deal with crises, so you can allow there to be a period of 4 to 6 weeks where you can do some psychological and social treatment work without having to resort to just using medications up front. Some of the individual factors might be controlled breathing, muscle biofeedback, guided visual imagery techniques, particularly for the older children, controlled breathing, muscle feedback for arousal regulation for the younger kids. And interpersonally, very much positive reinforcement for desired behaviour, attitudes, response cost, token economy, turn-taking, active listening, active ignoring of undesired behaviour. So you don't put your energies into a rewarding, if you like, of your attention and your energy around bad behaviours and unhelpful behaviours, but you put your energies into the positive reinforcement of pro-social behaviours and the child being able to turn away from their tantrums or their bad oppositional behaviour and actively looking for reinforcing positively them calming down from a tantrum or them beginning to turn away from being defiant and actively working with you. And good old-fashioned making and keeping friends, social skills training. All these aspects we try and work on with families. We also try and make sure we don't miss the deaf child and the blind child, and as I mentioned, clumsiness, speech and language difficulties, learning difficulties, we try and identify so we can set in place the tutoring, the motor learning programs, the speech therapy that's needed. But we do use medications, and we do use them particularly to facilitate the availability of the young person to learn, so they have better arousal regulation, better executive functioning or mood regulation, so they're able to better work with mum, dad, teacher, other adults, siblings, and learn the skills that you're wishing them to take in. With respect to medication, medication can really have a very important role in helping the child invest in the psychosocial treatment program and learn. Although it can take up to 6 months, as I said, to learn those new habits. So it's very, very important that we don't, in a sense, discount the role of medication, but that we use it in order to help the child be more mindful and able to engage and learn. Biologically and psychologically and socially, we're wanting to maximise resilience and minimise risk factors, and medication definitely has an important role in that. We want to start low and go slow, as well as finish slow when we're thinking about using medications. There's no doubt with respect to medications that the stimulant medications, dexamphetamine and methylphenidate, are the first line treatments. Second line would be atomoxetine or Strattera, the trade name. And third line we have guanfacine now, or Intuniv, which can be very, very helpful medication to be used alone or in association with the stimulant medications. But we use those medications when the psychosocial interventions have been insufficient to actually help the family and the school and the child's world move ahead. Medication can help the child be able to learn, and there's no doubt that it has a role. But I think it's very important to put to you that I don't believe medication should be used, particularly in high doses, if the child's ability to learn socially, academically, school, home, wider society hasn't been given careful attention. Because why have the child be more mindful, have better information processing, or be more inhibited if they're immersed in an environment that isn't in any way attuned to them, isn't empathically understanding their situation in life, and isn't, in a sense, cued to developing a more detailed path that's unique and helpful for that child out of their ADHD and into a set of skills that can help them better manage in their life. So I'll put to you, ADHD is a developmental problem. It's not just a neurodevelopmental problem. I think that's a misinterpretation of the literature. Yes, there are aspects of brain developmental delay evident in this group of young people, but it's by no means all that explains their ADHD. And likewise, medication alone is an insufficient treatment for this group of young people. They need to be taught skills, and they need to be taught skills by a range of people. Mum, dad, siblings, as well as key teachers, mentors and others in their wider social lives, be it a local church youth group, be it a netball club, be it a footy club, that can engage and help the young person reflect on their behaviour and internalise new ways of self-understanding and skills that can work better for them. It takes young people with ADHD a lot longer to learn these skills, and that's important. So you have to learn to be patient and understand that young people with ADHD can get angry and irritable very easily, and indeed that can be linked to a developing anxiety or depressive disorder that may need separate management. Either way, whether comorbid anxiety or depressive problem is evident or not, these young people can take longer to learn skills and can be very moody and emotional, and we need to be patient. However, it's very important to understand that they have strengths. These young people in different social, cultural contexts can have lots of energy, be very creative, can try new things, be very exploratory and very much open to exploring and experiencing new things, and can have very, very good reflexes in particular sporting situations, and can act quickly and can focus a lot on particular tasks that immerse them and interest them. And they can achieve a lot even despite having this condition. It is not all bad, and I'll put to you, that's the truth in terms of all psychiatric patterns of symptoms. There are good and bad elements to all experiences. It is not just uniformly bad. There's always elements of good, and we can build on those for that unique young person and their family. So, that's my last overhead. ADHD has many different varied biological, psychological, social and cultural determinants that add up in countless ways to lead to the onset of disorder. We used to believe that we might find moderating and mediating factors that would predict certain pathways, perhaps a few, 3 or 5, into ADHD. We now know that's not the case because there are so many factors of small effect adding up for a particular child and family. ADHD management has to be holistic and uniquely tailored given that fact. It is not enough, as I mentioned earlier, to just use stimulant medication in a standardised way. For every 10 individuals given stimulant medication with ADHD, around 8 will respond positively, cognitively and behaviourally. But there'll be 1 out of 10 that won't have any benefit from the medication, and there'll be 1 that will actually have cognitive and behavioural decline. 10%. Now, the literature doesn't emphasise that, again, because of these group data regression lines. But you, as a clinician, when you have that unique child, young person, family in front of you, don't know if they're going to be in that group that will have a positive response, cognitive and behaviourally, to the medication, or they may be that 1 out of 10 will actually get worse. So you have to uniquely tailor and trial all these interventions so that they're holistic. They're going to maximise resilience, minimise risk for that young person, with you, with them and the family and teacher, etc., monitoring, almost like a little village, to help raise that child, that young person, so you can maximise their strengths and you can minimise their risks, and you give them the very best chance to move ahead in an effective way with their life. Thank you.